Welcome to the Radiology Field of View podcast, the show that explores a wide range of innovations, challenges, and opportunities in radiology practice management today. I'm your host, Dr. Benjamin Strong, Chief Medical Officer at vRad. In each episode, we'll speak with imaging leaders for their unique perspectives and practical insights to help move your practice forward. Let's get started. Welcome. Thank you for joining us. We are here to discuss the essentials of radiology practice management. I'm Dr. Benjamin Strong, the Chief Medical Officer of Virtual Radiologic, or vRad, and I'm joined here today by two of our medical directors, Dr. Scott Baginski and Dr. Nina Geatrakas. Thanks for joining us as well. There are many pressures on radiology practices today. They include increasing imaging volume, decreasing radiologist capacity, many practice events such as consolidation, contract loss, and even group implosion. And all of these are leading to tightening margins and much more difficult practice management in general. So we're here to share a few strategies that we have found to be effective over the years. We're here in our Minneapolis offices, and I'd like to point out that Dr. Baginski is primarily involved in the management of our radiologists, and Dr. Geatrakas is involved primarily in our client practice management. So they both have unique perspectives to bring to this discussion. So with that, we'll dive right in.
Let's do it.
All right. Well, we'll start with Nina. So, Nina, from the client perspective, what do you think are the biggest pressures confronting radiology groups today?
You already alluded to it, Ben, talking about record high imaging volume. I'm struck by the volume both here that we see at vRad and out in the market, hearing from our clients. There are many factors. First of all, it's just a record number of patients going through the system. The Affordable Care Act has improved access to care. So more patients are going through the system. Really, healthcare depends largely on imaging. I always call it the funnel, that radiology is the department that's the funnel everyone runs through.
Or bottleneck.
Or the bottleneck.
As the case may
be. Can be. But it absolutely is. Medical care in the United States very much depends on medical imaging. That's how diagnoses are made, and our clinicians depend on that. We have an aging population, so older patients are typically overrepresented in medical imaging anyway. And with the baby boomer generation aging, we have many, many more patients in the system. And we also have, the U.S. has an increasing number of mid-level non-physician clinicians. There is some evidence out there that those clinicians rely even more so on imaging to support their clinical management of the patients.
Let's go to Scott, and for the radiologist perspective, how are radiology groups feeling these pressures, and what are you hearing from the radiologists, both at vRad and externally, that you discuss these issues with?
Yeah, sure. So first of all, everyone's recruiting. I mean, this has got to be one of the best radiologist job markets that there's been known to mankind at this point. So what happens is everyone's competing for that scarce resource of radiologists, and that's driving up compensations quite a bit. As far as what are radiologists not doing, or radiology groups not doing to respond to these pressures, so I talk to a lot of radiologists who are looking to switch practices. And a common theme seems to be that there's more emphasis on recruiting than retention. And so, Nina mentioned the incredibly high volumes that all the radiologists are acutely feeling, and it's leading to physician burnout. So when you used to be able to leave at 5 p.m., now maybe you're leaving at 6 p.m. or 7 p.m., and that just cycles, and you eventually burn out your physician. So practices that are not able to meet or match their capacity and demand are having that felt on their radiologists, and it's leading to burnout.
That is an interesting point you make, that I just am realizing that at vRad we really view retention and recruitment as two sides of the same coin.
Yes, indeed.
It's absolutely critical, perhaps even more so, that you retain radiologists. Otherwise, your recruitment efforts are essentially for naught.
Yeah, it's just a continual cycle of churn, which nobody wants.
Indeed. All right. Well, how are these pressures showing up in radiologists' day-to-day experiences? Certainly, you've mentioned burnout, but what are the other manifestations that you've noted?
I've had radiologists tell me that they feel like they're tied to their chair, that they can't get up, they can't take breaks, they feel like they're reading too fast and perhaps making more mistakes because of that. And then you mentioned the burnout, that there's kind of this spiral effect, which I've seen go through groups, where if you have one radiologist leave a group, for example, I think the average group size is 9 people. So if you have one radiologist leave a group, that puts a lot of pressure on the other 8 radiologists who now have to pick up that weight. And that just kind of spirals. And then so you have that keystone radiologist leave, and then you have another radiologist leave, and before you know it, the entire group dissolves. And I've seen that happen multiple times over the past few years.
Yeah, we see it quite frequently. In fact, that brings up my pie analogy that I so love to share, that many groups have committed to a fixed volume of imaging, say through a hospital contract, and it essentially equates to a pie that they have cut into equal pieces and ask every partner to eat an exactly equal sized piece of pie. And ultimately that pie is getting redivided into larger wedges that the remaining radiologists are required to eat. And it doesn't matter if it chokes them, and it doesn't matter if it leaves them hungry. And so it's a real quandary. And it comes from ultimately, I think, having committed to a fixed volume of imaging that a given practice must cover.
Yeah, and you mentioned that, and that who bakes the pie, though, right? Is it the radiologist group, or is it the hospital system, or is it the imaging center? And so if the hospital system continues to bake a larger pie, then that is just felt more acutely on the radiologists themselves if they can't control the amount of pie that they have to eat.
Yeah, right. Yeah, and it is not in the control of most radiology groups. Sorry, Nina.
No, it makes me think about, basically, it comes down to managing capacity first, and then go out and get your demand, go get your volume, go grow your practice. But know that you have the radiologist there to do the work. And that's not always the order in which hospitals and healthcare systems plan to grow. And that can be the challenge, but the pressure falls ultimately on the radiologists.
A lot of groups have pressures from external sources. It might be corporate ownership. It might be a hospital system. It might be, for that matter, academic administrators. But ultimately, they have to, I think, take more dramatic steps towards controlling the volume that they are being forced to cover.
Yes.
And that is a difficult proposition.
Yes. Yep.
All right. And Nina, perhaps you can talk about the impact that you're seeing of these pressures on hospital systems. And have you seen that they have adjusted to these problems, and have they made any effort at controlling the ultimate imaging volume?
So to answer that first, it seems generally no. We have not seen in our client base and in conversations with players out there or organizations out there. I think it's benevolent. I think they do feel there are patients to care for and they need to go care for them. But I do see that the radiologist capacity consideration comes after the identifying we need to go get this imaging volume and then we'll figure out how to read it. That does seem, unfortunately, to be the order. So from the teleradiology perspective, it's interesting. We've always done teleradiology at vRad. This is what we do. What we're seeing in some areas in particular is hospitals and healthcare systems attempting to hybridize their workforce, their radiologist workforce, offering fully remote or hybrid remote on-site. Unfortunately, many of them are struggling now because they did not build the technology infrastructure to support that. And we're very familiar with that on our side, that's really baked into the fabric of what we do. But from a technology perspective, if you want to have remote work for radiologists, you have to have your hardware, your software, and your support, your IT support. And we are seeing in our client base some struggle there from that end.
So let's talk more about how groups can respond. So we've addressed the less controllable aspect of this equation, which is the imaging volume to which any group is committed. But what else can groups do to stretch their capacity and address it from their side? So you mentioned certainly the hybridization, the offering of remote reading positions.
Yes.
What other sorts of strategies have you seen in hospital systems?
Certainly, they are turning to organizations like vRad to help be a virtual FTE. That is a big factor. We are virtual FTE in many places, many facilities, and I have heard from many radiologists on site that that's an essential part of their workforce, that they can't do it without us.
Well, so we've discussed the difficulties in controlling the volume that a
Yes.
given group is committed to covering.
Right.
And obviously that's fraught with difficulty. But what other strategies are you seeing that health systems are applying to manage the other side of that equation, which would be radiologist capacity?
Right. So fortunately, we are starting to see some indication that hospitals, healthcare systems, and even radiology groups are beginning to use data analytics. So this is something we're very familiar with, and I'm glad to see others out in the market becoming more familiar with it. But basically, the idea of understanding what historically has happened year over year, month over month, when are your high points? Summer in a certain area may be very busy. You're going to have a lot of volume. You can predict that. You can plan for that for next summer. So it comes down to data analytics and collecting the data to have historical information that allows you to then predict what to expect coming in the future. And then you can plan your capacity, schedule your radiologists appropriately.
And that's a big shift from the traditional approach. This sort of operational management hinges on initially predicting the volume that you will be receiving during any given hour, day, week, month, or year,
Right.
and then staffing to it.
Yes.
And in contrast, kind of the traditional model is that a practice simply puts a radiologist in a given chair for a given time period.
Right.
And that poor radiologist is then responsible for whatever comes his
through
way.
the door. That's right. Right. And as Scott said, stay till 7 p.m. because that's just how much work there is. And that you can only ask that of the radiologist for so long before they go, this is not how I want to work. Yeah, absolutely. On the ground, we also see, and this doesn't apply as much to us, of course, but on the ground in a hospital-based practice, there is some increased utilization of RPAs, the radiology physician assistants, who are able to do light IR procedures, certainly the fluoro procedures, which most radiologists are happy to hand off and are time consuming. And that amount of time you spend in a fluoro procedure, you could actually be reading many films, many cases. So there is an increased lean on RPAs in the system. Some hospitals talk to us about attempting to track imaging utilization and ordering patterns by their clinicians. We are able to provide the data for that, and it'll be interesting to see if that bears fruit in the future. We know that they're just starting to tap on that particular avenue. We don't know.
Well, it's one that they bang against time and time again, honestly, historically.
Right.
I hear it come up at most conferences. Someone, usually a younger radiologist, will talk about, can't we reduce the imaging utilization by our clinical brethren? And we can actually track the percentage of positive or critical findings found by any given provider's ordering behaviors.
Absolutely.
But what we have found is it falls on deaf ears at the hospital level and at the clinical level. Most of them are pretty resistant to efforts to rein in their imaging ordering behaviors.
Understandably, there are pressures on them. Patients expect it. Patients are very familiar with imaging, and if they don't get it as part of their care plan, they ask for it. And medical malpractice risk is higher than it's ever been. The payouts are higher than they've ever been, and the number of cases are higher.
And as a former ER physician, I can tell you it is not well received, these efforts to limit people's ordering behaviors.
No.
And the med-mal is, or at least for me, was the primary driver in my resistance to those efforts. I always felt that, well, you're letting me hang out there
Yes.
with all the risk. And
Yes.
when something goes south because of my failure to order an imaging study, you'll be nowhere to be found.
Right.
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 You
Yeah.
being the hospital
Yes.
administrator or the
Yes.
radiologist trying to limit my ordering.
Yeah. Yeah.
Well, let's move on to Scott and see what sort of individual radiologist behaviors have you seen to try and manage that radiologist capacity side of this equation?
I think there are a few things you could do, other than working longer hours and harder. You can do some things on the system level that kind of take away the queue pressure, or the work list pressure, the queue pressure that the individual radiologist has, right? So you can either have a certain number of studies assigned just to the radiologist and then they drown in it, or you can you can share that work list across the practice and let everybody work at their own pace and everybody chips away at it. And then if you pay on a pay for productivity model, that's a very equitable model, and it allows everybody to contribute and to, like I said, work at their own pace, decreases burnout, allows folks to take breaks. So I think those are some strategies you can have to decrease burnout on the individual level. Like, you want the queue pressure to be felt by the system, not by the individual radiologist,
right.
if that makes
Yeah.
sense.
And those two things do go hand in hand. A lack of the elimination of siloed work lists,
Yes.
and the expansion of access to all the studies works very well to reduce queue pressure, but it almost has to be paired with a productivity compensation model of some
Indeed.
kind.
Yes.
Absolutely.
Yes.
The other thing you can do is, as far as the equitable practice, is make your own internal work unit values that are more in tune with the time that it takes to actually read a study. If you look at the CMS work unit values, they're often out of kilter with the amount of time that it actually takes. They can vary widely. So it's not as an equitable strategy as if you make your own internal work unit values.
Right.
Yeah.
Yeah, that has been a huge advantage. Actually, we looked at CMS RVUs and tried to make sense of it based on reading times, specialization, all the elements that we could consider, and it is utterly lacking in logic.
Yeah.
And I actually asked an ACR colleague of mine how that came about, and he said, well, it was the politicized process that generated the CMS RVUs. He said it was essentially like the trading floor of the New York Stock Exchange, with people yelling and screaming and waving fistfuls of papers at one another, and horse trading, essentially. And the output from that is, it's clear that his description of it was accurate, because we were unable to find any logical thread through CMS RVUs. And so, yes, as Scott mentioned, we've made our own RVU system that's much more equitable, that is tied to the average reading times for given procedures, and even accounts for the level of specialization that a radiologist might have. So that's been very helpful as well. That's a good point.
The other thing you can do is you can have, you have to compensate people based on kind of how difficult the shift is, right? How difficult is it to get a radiologist to read during that time of day or night? And so if you have a time variable compensation model where the nighttime obviously pays more than the days because it's harder to get to staff the nights, the weekends pay more than weekdays, the holidays pay more than non-holidays. So again, trying to make a more equitable compensation system across the board tends to reduce burnout.
And those two concepts come together in our creation of the hot potato list.
Yes,
That's
hot
just
potato
realize
index, yes.
there are some procedures that are disproportionately disliked by radiologists, and it goes beyond, say, the amount of time it takes to read them or the specialization required to read them. There are just certain procedures that are difficult to dictate, perhaps just for whatever reason less desirable. And so we call those the hot potatoes, and pay extra for those procedures to be read as well.
Yeah, the CTA runoff comes to mind immediately.
It sure does.
runoff.
That's number
A
one.
lot of vascular ultrasound studies.
Sure.
Yeah.
Absolutely.
Well, that's great. All right. Well, let's move on to a larger level practice discussion. So, Nina, why don't we start with you? What's the difference between a practice that's reacting to change as opposed to one that's truly built to handle it?
Yeah. It's an important question. We talked a little bit about it earlier, talking about the technology infrastructure. I guess I'll just say it again because I think it's essential and we should really make sure we're getting that message out there. That has been really a make or break for many hospitals, being able to let their radiologists work supported with 24-hour IT support and working in the manner and location in which they want to work. I also see a very important correlation between the relationship a hospital has or a group has with its hospital administration and the success of the group. I have seen radiologists completely marginalized, radiology groups, individual radiologists completely marginalized because they don't have a robust relationship that recognizes the mutual benefit of working together with the hospital administration. I think that's very, very important. And I see it over and over. We have many, many clients of different demographics in terms of practice structure. We have groups which are employed by the hospital and have wonderful relationships with the hospital and they feel solid, they're supported. We also have the opposite, where they don't have a great relationship. We have private practice groups. In particular, those are vulnerable. And we've seen all across all of radiology, not just and you'd mentioned it earlier, group consolidation and implosion at the intro. That's a very important factor, is how well you work with your administration and how well you understand each other and mutually benefit.
Yeah, absolutely. In fact, we're seeing that as a theme throughout all this, right? Controlling the incoming volume, having the underpinnings, the infrastructure to manage things. A lot of these are dependent on your relationship with your providers.
Yes. Yeah.
Well, Scott, anything to add to that? And I would even add, have you seen any practices or radiologists who've worked for practices that are actually in those quality relationships, actually shielded from the excesses of volume, et cetera? Are they out there?
Yeah, absolutely.
How have they managed to be that way?
Actually, the radiologists that come to talk to me are usually looking to change practices. So I tend not to hear about the
happy stories.
The happy ones. But no, I'm sure they are out there. And I agree with Nina. You have to have that great relationship between the hospital administration. You got to be on the same page as the radiologist.
Right. It's a little bit scary to see how many, and you know this, you've talked to these radiologists who suddenly don't have a contract anymore. Suddenly the hospital or whoever, and that can happen whether you're a private practice or employed, but we know we have many of those rads who have come to us, but it's a little scary to see that be wiped out.
Yeah,
group implodes.
It speaks to the power of the larger practice, right? The stability of a larger practice that has, maybe you have 50 client sites or 100 client sites. You always hate to lose a client site, but if you have 100 of them, then you're not going to have that effect on the radiologist, on your volume acutely.
Right.
But yes, I have definitely talked with a lot of radiologists who staff one hospital, and the hospital sells the contract out from underneath them.
Yes.
And 6 months later, they're looking for a job.
Right.
Well, we've certainly seen the radiology landscape shift dramatically in the last few years. What sorts of patterns or changes have happened that aren't being talked about more broadly?
I think I'll take that. Sorry, Ben.
No, you take it. It's yours.
I think one that's not talked about nearly enough is on the macro scale of training enough radiologists. We simply do not have the right trajectory of the amount of radiologists being trained into the system compared to the amount of images that are coming in and the number of patients that need to be cared for. So every year they increase the number of residency spots by a few dozen or something like that. Our practice alone could absorb all of those residents, and we wouldn't even blink, right? We could So
We'd be grateful.
we would be very grateful, very grateful.
We'll take them.
But it would not move the larger
It wouldn't
needle.
exactly.
Right.
It's so, and I think if we don't do that, Nina mentioned mid-level providers earlier in the conversation. I think that's a threat to the radiology in general. Like somebody's gonna, if we don't solve this problem ourselves, somebody will solve it for us.
Yes.
Yeah,
Yeah.
absolutely. I've always thought that's one of the biggest risks to radiology is being unable to handle the imaging volume. That's exactly the situation that leads to neurologists reading their brain MRs and
Yes.
pulmonologists reading their chest CTs, and on. The list is enormous of people lurking on the fringes waiting to poach what are traditionally radiologist responsibilities.
Many states have legally now allow autonomous practice of mid-level clinicians. And so to your point, at some point we are going to see, or may see if we don't fix it, we will see them reading films. Mm-hmm. They already do in many settings. Orthopedic offices take their own images. Often whichever provider is caring for that patient, mid-level or physician, they are actually issuing the interpretation of the imaging. So it's out there, lurking.
Trying not to make a noise. I couldn't.
Couldn't help it.
All right. Well, along those same lines, is there anything else that people, hospital leaders, radiologists, practice leaders, even policymakers, is there anything they should be paying closer attention to, or are there any steps they should be taking?
I think so. I'm glad that you asked this because we will give a sneak peek, I think, to talk about artificial intelligence, mentioning it here. This is a titanic topic, as we know, and especially in radiology, certainly in all of medicine, but radiology is really the core. That's the heartbeat of AI in medicine. We will talk about this in the future. We'll be diving into AI. But what I want to say here and leave you with is something to think about as radiologists. So patients are very rapidly adopting an acceptance of AI in medical imaging. I think this is human nature. They see AI in other areas of life and they just accept it. So they are increasingly accepting AI's role. It really is now or never the time for radiologists to build relationships with patients. When we hear patients saying they would be very comfortable with just AI reading their cases, where does that leave us? And we are still their radiology doctors. And I want to plant the seed to think about in the context of AI and the context of the core of what we do, being radiologists caring for patients, is let's get to know the patients in some way, building that trust so that they feel confident in the future of AI and radiology working together.
You know, I have an interesting spin on that because I do have to cite the failure of the ACR's Imaging 2.0, which was to say, let's get the radiologists out of the basement and shaking hands with patients and whatnot. And it was very poorly received, and in fact, very quietly died a death of neglect. Right. But I would tell you, the fundamental, essential element of a successful physician-patient interaction is knowledge of the workup to date. Showing that patient that you know where they came from, you know what situation they're currently in, and then moving to obviously help address it.
Yes.
And I think from a radiologist standpoint, that comes from access to the patient record, to prior studies, and their incorporation into your interpretation, yes, which makes it timely, informed, and relevant.
Yes.
And I think that is really the radiologist contribution.
It absolutely is.
That should actually replace in our minds the idea of developing trust with a patient and whatnot. It doesn't have to be through meeting them.
No.
It has to be through making sure that your report is, again, informed and timely and relevant. And that's how I think we beat AI.
Yeah, I completely agree. I have spoken with many patients in many different areas, client sites over the years. That is the expectation of the patients for radiology care. They don't expect us to walk out of our room and go shake their hand in the MR unit. They expect that we have the information, that we synthesize it, put it together, have the priors, and put it all into one meaningful interpretation of today's imaging. I completely agree with that. And that's how we do it.
Scott, anything to add for the radiologists out there, perhaps seeking new employment or...
Well, like I said, everyone's hiring. So is vRad.
Yes, indeed. The world is your oyster,
Yes.
I think is the
Indeed.
message.
It is.
The world is your oyster. This is, grab it while it's hot. Yeah.
Well, wonderful. This was great, you guys. I really appreciate you being here and sharing your thoughts. And clearly, radiology is facing a number of challenges, and we have put these podcasts together in order to share some of the strategies and experiences we have developed and had over the last couple decades. And we look forward to having many more such episodes in which we plan to go into far greater detail on each of the salient points that we've addressed here today.
Excellent.
So,
Yeah, glad
looking
to be
forward
here.
to more.
Yeah.
Thanks for listening. Thanks, Ben.
Thanks, Ben.